So I've been asked to talk a little bit about the pathogenesis and treatment of hepatic fibrosis and focusing on the question of whether reversal of cirrhosis is actually truth or myth. These are my disclosures. So as we know, liver fibrosis is the most important determinant for clinical outcomes from liver disease. So we'll talk a little bit about fibrosis and determinants of progression. What lessons have we learned thus far from clinical trials where fibrosis was one of the endpoints? And then we'll focus and discuss a little bit specifically about cirrhosis reversal. So as we know, really fibrosis is a natural wound healing response to any injury, whether that be viral hepatitis, alcohol, or NASH. The final common pathway is fibrosis. And when you talk about fibrosis, it's important to recognize that one key cell central to this process is the hepatic stellate cell. It lives within the space of Disse between the fenestrated endothelial cell and the differentiated hepatocyte. And what also makes the liver quite unique is that it derives the bulk of its blood flow from the portal vein, which is a low flow and low pressure state. And this allows for a lot of interaction between gut-derived pathogens, circulating cells of the immune system, with the resident hepatic cells. Now, normally it's a vitamin A-rich cell that produces predominantly type 4 collagen. However, with activation from any injury, it undergoes classic phenotypic changes where it becomes more proliferative, more contractile, and now starts to produce these high-density interstitial type 1 and 3 collagens. And so depending on the etiology of the liver disease, a number of stimuli are converging to activate the stellate cell and perpetuate that activated state. But I think it's really important to recognize that this is a very dynamic process. While at the same time collagen is being laid down, there are mechanisms by which the collagen is being resorbed. And so depending on which process is winning, if fibrogenesis is outpacing fibrinolysis, you will have net scar accumulation over time. So when you think about the activated stellate cell under the influence of the most potent profibrogenic cytokines, TGF-beta 1 and CTGF, it's producing type 1, type 3 collagen. These are individual fibril bundles, which are then cleaved, and ProC3 recognizes the epitope of the cleaved fibril, and P3NP is the N-terminal cleavage product. Once those fibrils are cleaved, they then join forces with a number of other glycoproteins, such as fibronectin, laminin, and hyaluronic acid, to form these collagen bundles. These bundles are then extensively cross-linked by an enzyme, lysyl oxidase. And then at the same time, you have matrix metalloproteinases, which are trying to chomp at that collagen, and you have TIMPs, which are inhibitors of MMP. So the balance of MMPs and TIMPs can be important in promoting fibrinolysis. Those fragments are then broken off. C3M is the MMP9 mediated degradation product of type 3 collagen. And so these glycoproteins and collagen fragments are released into the blood and form the basis of some of the non-invasive markers of fibrogenesis that you may have seen or heard about in the context of clinical trials and now actually in the context of clinical care. For example, ELF, which is a combination of P3NP, hyaluronic acid, and TIMP1. And really what we learned during hepatitis C, which still holds true with any type of chronic liver injury, most people, it takes about 30 years to develop cirrhosis. However, there are individuals who we'll call rapid fibrosers who can progress to cirrhosis within 10 years. And then we've all had those 80-year-old women who had a blood transfusion during spring break in college, got hepatitis C. They're coming to you now, they're 70, 80 years old, and they have no fibrosis from that hepatitis C. So we have rapid, intermediate, and slow fibrosers. So what are determinants of whether you're going to be a slow, intermediate, or rapid fibroser? Certainly, there are some genetic predeterminants. there was a cirrhosis risk score in the context of hepatitis C where 7 SNPs were associated with an increased chance of having cirrhosis. And we've heard a lot about PNP, LA3, and HSD17 in the context of NASH, but they're also relevant for other liver diseases. But specifically, PNP, LA3 is strongly associated with fibrosis progression, HCC risk in both NAFLD and ALD, alcohol-related liver disease, may increase the risk of cirrhosis in Hep C patients, and is associated with increased liver stiffness across a range of values, even between 12 and 24, indicate that it reflects active fibrogenesis and progression of cirrhosis. On the other hand, there are protective SNPs, where HSD17 is a loss of function variant, which decreases transaminases, reduces the risk of alcohol-related and NASH and cirrhosis, and protects protection from NASH in individuals with fatty liver disease. And so you have a genetic predisposition, and then you have the environment where you have a complex interplay between different diseases, concomitant diabetes, obesity, chronic kidney disease, et cetera. You have the impact of social determinants of health, poverty level, diet. And then you have environmental factors, exposures to toxins like the World Trade Center, alcohol, and the protective effect of caffeine. And so the actual disease course will be modulated to determine the reality. So you have the genes plus the environment that will dictate actual disease course. Now, in the context of clinical trials, when we see eligible patients, we have no idea at that point what their risk is or whether they're a slow, intermediate, or rapid progressor. And we don't really know all of the environmental factors that they may be exposed to. And so you can imagine when we stratify these patients for a clinical trial, we could inadvertently have more rapid fibrosers in the placebo group and more slow fibrosers in the treatment group, resulting in unequal stratification and making your drug look effective when it really may not be. So ideally, we would like to have equal stratification of these patients, but yet that's not practical at the moment. Most studies do post hoc analysis to look to see whether or not there are factors that predict more rapid progression in patients, but it's not practical to design the studies at this point with this way because you would take a long time to accrue patients. Say you just wanted to have patients who have PNP, LA3 polymorphism. It would take longer to enroll those patients and longer to get the power to be able to look at to see an effect. And then also from a marketing perspective, you're saying that your drug is only applicable to that population. And so while there are a lot of post-hoc studies, and now we're starting to see clinical trials which do this and really try to enrich their population with those who are most likely to progress and maybe more relevant to the mechanism of action for that particular drug, this is a field that's emerging. Now, we know that fibrosis for sure and cirrhosis is reversible. And there's evidence in hepatitis B, curing hepatitis C, NASH with bariatric surgery, secondary biliary cirrhosis with decompression, et cetera. So we know that fibrosis and cirrhosis can be reversible, but not necessarily in everyone. There may be a point in the cirrhotic phase where it's really too little, too late, and we'll talk a little bit about that in the upcoming slides. So what are determinants of reversibility? Well, the more rapid the onset, the more likely the regression. Fibrosis, when it's laid down, it's very feathery, it's very light, it's very thin. So you can imagine it's very easy for those MMPs to break that down. The more cells you have, the more sources of those proteases. And so when your scar is acellular, it may be less likely to be resorbable. The more cross-linking that you have, the more insoluble and stiff that collagen gets. And the more elastin and mature cirrhosis is more resistant to degradation. The thickness of those fibrotic bands, they're more inaccessible to those proteases, and there's more architectural disarray that may not be able to be recovered even with therapy. There's this delicate balance between MMPs and these inhibitors of those enzymes, such that high TIMP levels may impede regression. And then, of course, there's other factors. We talked about genetic determinants of progression, but are those the same genetic determinants of regression? And I think that's something that we will learn about more in the future. So there are a number of points of attack or therapeutic approaches to reduce fibrosis. Obviously, we know getting rid of the upstream injury is probably the best anti-fibrotic, antiviral therapies, alcohol abstinence, etc. But then you want to try to decrease activation of stellate cells through different mechanisms to protect hepatocytes from injury. Once the stellate cell is activated, you want to try to reduce some of the phenotypic features of that cell. You want to inhibit its proliferation, inhibit its fibrogenesis, etc. And then you have these activated stellate cells. And when you want to stimulate regression, you want to either push them back to the quiescent state, you want to force them to the apoptotic pathway, or force them to the senescent pathway. Specifically with NASH, because obviously the most clinical trials that we have that have fibrosis as an endpoint are in NASH. Conceptually, you want to decrease the flow of free fatty acids and insulin resistance that promotes lipotoxicity within the hepatocyte, decreasing the inflammatory signaling, chemokines and cytokines that promote inflammation. You want to then prevent apoptosis and oxidant stress, all of which are activating stellate cells. And then, of course, direct anti-fibrotics, drugs that might be acting on the stellate cell itself directly. And so it's been, for those of you in the field, it's been, a difficult path where we have had a lot of failed studies. But I would say that with each study, we learned something and we made progress, and we built upon that progress, getting us closer and closer to therapeutic options to treat fibrosis. And so I'm going to highlight just some studies where I think something was learned that helped us advance the field, starting with the earlier F1 to F3 fibrosis, and then we'll get into cirrhosis itself. And so the Golden trial, which looked at elafibranor, if you guys recall, in the phase 2 study, their primary endpoint was not met, reversal of NASH without worsening of fibrosis. However, what we learned was they enrolled patients who had a NAS score of less than 4, and they saw a 57% placebo response rate. However, when they did a post hoc analysis, and they specifically focused on patients who had a NAS score greater than 4, in a modified intention to treat analysis, they were able to see an effect. So we learned that patient selection is very critical. You need to enrich the population for those who are most likely to progress, higher baseline levels of inflammation, fibrosis. And while this is specific to NASH, the presence of ballooning became kind of a big deal. All studies after this required at least some ballooning in order to be included. And whether that was a good or bad thing could be debated, but this did change how trials were designed moving forward. Unfortunately, when they moved on to phase 3, they did not see an effect, emphasizing that NASH is complex and heterogeneous. Again, high placebo response rates plague the field overall. In this case, weight gain was not an issue because it did not have the gamma effect. Now, what about Cenicriviroc? Cenicriviroc is a CCR2, CCR5 antagonist. It inhibits Kupffer cell activation. It inhibits the recruitment of macrophages, monocytes and macrophages into the hepatic parenchyma, and it has direct anti-fibrotic effects on stellate cells. So it really checked the box in many of the downstream effects of lipotoxicity. Now, in the Centaur phase 2b study, they enrolled 289 patients, and they tried to enrich those who are more likely to progress during the time period. So diabetes, higher BMI, and now you had to have bridging fibrosis and definite NASH. this was at 1 year, the biopsy, the primary endpoint was a 2-point improvement in the NASH score without worsening of fibrosis. Secondary endpoint, resolution of NASH without worsening of fibrosis, or improvement in fibrosis stage without worsening of NASH. And so they did not meet their primary endpoint. However, what we saw here was that their key secondary endpoint, where they saw an improvement in fibrosis stage with no worsening of NASH. So this was really the first time where there was essentially this decoupling of the inflammation and fibrosis. The paradigm had always been, and perhaps still is that inflammation injury drives fibrosis. And so to not see a decrease in the inflammation and injury, but yet see this improvement in fibrosis suggested that maybe this was a direct anti-fibrotic, and the bulk of its effect was directly on the stellate side. So they then crossed over 50% of their placebo arm into open label and did another biopsy at year 2. And unfortunately, that improvement in fibrosis in year 1 was not sustained in year 2. And you didn't see everything moving in the right direction. So there was no decrease in ALT. There was no decrease in fibrosis biomarkers such as the ELF and the PRO-C3. There was a sustained anti-inflammatory signal. So this idea of the theme here is that everything has to be moving in the same direction. Everything has to be making sense. Once you have discrepancies, then you need to be a little bit more rigorous in your data analysis. This also suggested that there's a lot of biologic redundancy in this drug, in this disease, lack of potency, and this is now being investigated in a combo therapy with terpexafor. What about the ASK1 inhibitor, serloncirtib? So ASK1 promotes a cell death, fibrosis, and inflammation, and therefore inhibiting ASK1 would theoretically decrease hepatocyte apoptosis, decrease stellate cell activation, and decrease macrophage cytokine secretion. STELLAR-3, which focused on F3 fibrosis, failed to meet its primary endpoint of greater than 1% decrease in fibrosis stage with no worsening of NASH. And I should mention, actually, the other thing that came out of the Cenicriviroc study was that now everybody included this greater than 1 decrease in fibrosis stage with no worsening NASH as either a secondary endpoint or often a co-primary endpoint, where you could either have this improvement in fibrosis with no worsening of NASH or improvement in NASH without worsening of fibrosis. Now, the problem with this study is they actually did not base it on a placebo-controlled phase 2b study. The data came from a phase 2 study with simtuzumab, where it was kind of assumed that simtuzumab was completely equal to placebo at low potency and may need combination therapies. And so, So then we have the obeticholic acid study, which I think you probably know the most about. So in the Regenerate study, obeticholic acid, they achieved their primary endpoint of fibrosis improvement of greater than 1 stage with no worsening of NASH in a dose-dependent fashion at both 10 milligrams and 25 milligrams. In the intention to treat and included stage 1, they did meet the endpoint as well. They did not meet the endpoint of NASH resolution with no worsening of fibrosis, except for in the intention to treat stage 1 at the higher dose. So this was presented to the FDA, as many of you know, and essentially the FDA said you need hard clinical outcomes for approval. As you know, one of the downstream effects of obeticholic acid is an increase in LDL. And so many of the patients during the study were actually started on a statin or an aspirin. And so when the number 1 cause of death in patients with NASH is cardiovascular, this was clearly a concern that it increases the cardiometabolic profile. One could argue a statin can deal with it, but nevertheless, that was something that is clear, that cardiometabolic profile, when you need long-term therapy, you want to do no harm. As many of you know, there was a press release just recently that they have additional data that supports their efficacy. And so we look forward to seeing whether or not that will get them, over the hump and get approval. Now, so downstream of obeticholic acid is FGF19. That is one of the effector molecules of obeticholic acid, but endogenous FGF19 may have some carcinogenic effects. And in patients who are at high risk for development of HCC with chronic liver disease, that could be a potential problem. So FGF19 is a recombinant analog that maintains, doesn't have the oncogenic potential, but maintains the other biologic efficacy. And when they looked at this in a 12-week study, they saw that the corrected T1 or Perspectum, Multiscan, Lift Score, many different names, but corrected T1, they saw improvement in the liver fat content, the inflammation score that correlated with an improvement in NASH score on biopsy, and also correlated with histologic response. And you see that everything's moving in the same direction. Pro-C3 going down, ELF improving. Again, things moving in the same direction, increase your level of confidence. When they move this to phase 2B study, however, their primary endpoint of fibrosis improvement greater than one stage with no worsening of NASH was not met. The biggest issue was that you can see in their 1 milligram arm, it was the same or worse than placebo. And so there was no dose-dependent effect here. And really, it was this issue that was the problem. However, if you look at every other parameter, a resolution of NASH with no worsening of fibrosis, you see a dose-dependent effect and statistically significant. Fibrosis improvement greater than one stage and resolution of NASH and improvement of NAS by greater than 2 points with no worsening of fibrosis. In addition, all the other markers were also moving in the right direction. Reduction in liver fat content, ALT, AST, Pro-C3, ELF, driven mostly by P3MP. And so this really, I think, to many just said, the biopsy is just not the place that we need to put our money when we look at clinical trial endpoints. And the FDA, we just need to prove to them that there are other good surrogate markers. So resmetirom, MGL3196 in NASH, this is a thyroid hormone beta agonist, and it operates under the assumption that NASH is driven by hepatic hypothyroidism, if you will. This has a favorable cardiometabolic profile, lowers LDL, lowers triglycerides, lowers fat. And so in their phase 2 study, they enrolled patients. They needed to have an MRI PDFF of at least 10%. This included fibrosis stages 1 to 3. Patients were diabetic on statin therapy, very representative NASH population. 2 to 1 resmetirom to placebo. And what they found was that their primary endpoint was a reduction in MRI PDFF, which they met. They saw a dose-dependent decrease in liver fat content. And what was important here was that the responders, they could identify responders. So those who had a 30% PDFF reduction at week 12 had higher rates of NASH resolution. Also, their key secondary endpoints were all moving in the right direction. They saw reduction in fibrosis markers, reduction in liver enzymes, again, positive cardiometabolic profile. I think what was also very helpful from this study was to look at biomarkers and following patient response to treatment. So at 36 weeks, those who were on placebo rolled over into open label. And so now you can see that in the blue is the patients who were on placebo initially, and then at 36 weeks, they moved over to open label. And then the orange is just openly resmetirom drug throughout. And so what's interesting here, if you look at the orange line, which is resmetirom throughout, you can see that the solid line is PDFF and the bars are Pro-C3. You see a gradual reduction in both of those parameters. When you look at the blue line, you see that there's no effect during the placebo arm. And then when they cross over to open label, you now see that reduction. That was also seen with FibroScan. And when you look at the ratio of Pro-C3 to C3M, which is fibrogenesis and fibrinolysis, you can see that in those in resmetirom, there was a gradual reduction favoring fibrinolysis as opposed to placebo. But when you look at the crossover, those in placebo start to now favor net reduction in fibrosis. Now, semaglutide, the GLP-1 agonist, has gotten a lot of attention now for weight loss, and that's an important thing to really discuss in the context of NASH. What this study did, though, was look at 0.1, 0.2, and 0.4 milligrams sub-Q versus placebo. And what they found was that, and this is 72 weeks, they saw resolution of NASH with no worsening of liver fibrosis. But they did not meet the endpoint of fibrosis improvement. You see here the mean weight loss in the different groups, 0.5%, 5%, 9%, and 13%. Keep in mind that this dose is not the dose that is being studied for, that is approved for obesity, which is 2.4 milligrams sub-Q per week. This is 0.4 milligrams sub-Q daily. So one of the big things is, will all of this, at least for NASH, come down to weight loss? So semaglutide results in a 75% of patients having a greater than 10% reduction in weight loss, and 35% have a greater than 20% reduction in weight loss. So certainly something to think about as we move forward in the NASH studies, and that's actually being studied now. Novo is doing the study of semaglutide at that higher dose for fibrosis endpoint. So let's focus a little bit on cirrhotics, because I think that that's really where we have seen the most disappointing results, and thus whether kind of asking whether or not reversal of cirrhosis is actually a reality or a myth. But I think we really have to think about cirrhosis a little bit more carefully. Cirrhosis F4 is not a single stage, and rather it is the longest stage of fibrosis. Patients can be in the cirrhotic phase for 10 plus years. And someone who just entered cirrhosis, transitioning F3, F4, you're seeing them, they're F3, now they're F4, is very different than somebody who's been hanging out in that cirrhotic F4 stage for 10 years. There is active fibrogenesis and angiogenesis happening. Scar is still being laid down. It's still being cross-linked. There is decreased nitric oxide, increased intrahepatic vascular resistance. Those scars, the bundles, are getting more and more acellular. They're getting thicker, making them more and more insoluble, and at some point, potentially no longer able to be resorbed. But when you enter patients in these F4 studies, you don't know where they are in that continuum unless, again, you have been watching them transition into cirrhosis and you know that they have just entered the cirrhotic phase. I think the simtuzumab study was the first one that was done in cirrhotic patients that really gave us so much information, even though it was a negative study. So simtuzumab is a LOXL2 antibody, and it targets that enzyme lysyl oxidase, which is important for cross-linking that collagen, making it thicker and more insoluble. And so the idea is that by blocking that enzyme, you could facilitate scar resorption by restorative macrophages and matrix metalloproteinases. So patients had to have histologically confirmed F4, and they were randomized and stratified by diabetes and HVPG greater than 10, and the primary endpoint was a reduction in HVPG. Unfortunately, they saw no effect on portal pressure, whether you looked at who had a greater than 20% reduction, whose HVPG went down less than 10, either or, basically no effect. So maybe low potency, too little, too late. Again, as I made clear, patient selection for cirrhotic trials is very problematic. Negative results for PSC-compensated cirrhosis as well. They saw no change in collagen content after 96 weeks. But we learned so much from these negative simtuzumab studies. First, we learned that after a median follow-up of about 25 months, 25% of patients with NASH and bridging cirrhosis progressed to cirrhosis. After a median follow-up about the same, 20% of cirrhotic patients have liver-related events. So this really allows us to, power our studies because we have a better sense of the natural history in these more advanced stages. There were factors significantly associated with those who are progressing to cirrhosis. Higher baseline values and greater increases in hepatic collagen content. And I'll discuss that in a moment. So this is actually looking at how much collagen do you have, not are you an F4 versus an F4. Levels of alpha smooth muscle actin, which is a marker of activated stellate cells. So they're angry, they're pumping out collagen. An enhanced liver fibrosis score or ELF score. And on the corollary of that, an ELF reduction of greater than 5 units was associated with a significant decrease in risk of progression to cirrhosis in those with bridging fibrosis. We know that HVPG is an important predictor of hard clinical outcomes, though it's difficult to measure. There's a lot of variability from sites in terms of technical aspects and the results. And of course, it's very invasive. No patients really want to get that. And really, there's not much predictive value to baseline NASH. It just tells you that you have this, inflammation, and we can talk about ballooning. That's become a big issue because sometimes, just trying to find one ballooned hepatocyte, and there's a lot of the kappa on a pathologist's ability to identify ballooning is not good. And then in patients with advanced fibrosis due to NASH, again, same thing. The primary determinant of clinical disease progression is fibrosis and its change over time. It's more important to have dynamic assessments. A cross-sectional view of a patient really doesn't help you. But what you want to know is this patient have a slope that's like a rapid fibroser or more like a slow fibroser? And all we want to do is change their trajectory or change their slope. Serlonsertib, Stellar-4, just briefly, the F3 study failed. Similarly, the F4 study was actually terminated early because at week 48, they did not see any improvement in fibrosis or NASH resolution. They did see that fibrosis regression was associated with reductions in hepatic collagen content and alpha smooth muscle actin. So maybe by itself, it's not enough. So it's teamed up with a number of different drugs. So this is a combination therapy with cilofexor and furcostat. Cilofexor is an FXR agonist and furcostat is an ACCI inhibitor. And this is the ATLAS study that looked again at more advanced disease, bridging fibrosis and cirrhosis. Actually, 56% of patients had cirrhosis. And at the end of it, it did not meet its endpoint, which was greater than one stage in fibrosis without worsening of NASH. You can see that the combination of cilofexor and furcostat performed better than any of the other combinations. And that's kind of thematically across all of the different endpoints that were looked at, although it never met statistical significance. There was an improvement in LFTs, decrease in ELF score, decrease in FibroScan. But I think one of the important things was that when they looked at the slides and using AI machine learning techniques, they saw that there was a suggestion of fibrosis regression with this drug. And so this really, along with a lot of the other things that I've said, have really made the point that we need more refined ways to measure fibrosis using more advanced techniques. And we'll talk about that in a moment. So belapectin, galectin-3 inhibitor, in the phase 2b study, they have This is a weekly, every other week infusion. And they had baseline patients who had cirrhosis, HVBG greater than 6, no complications, no evidence of decompensation. And at 54 weeks, HVPG is the primary endpoint, as well as a number of secondary endpoints. And what they found was that there was no reduction in portal pressures versus placebo. But if they looked specifically at those who had no varices at baseline, they did see at that 2 milligram per kilogram dose a reduction in HVPG, and therefore this is now being evaluated in NASH cirrhotics to look to see whether it prevents the development of esophageal varices. Now, amikacin is a pan-caspase inhibitor and was looked at in patients with NASH cirrhosis with severe portal hypertension. Had to have a baseline of greater than HVPG of greater than 12, and the primary endpoint was a change in HVPG at week 24. And when you look at every which way you want to slice and dice this, all subjects compensated with varices, without varices, decompensated, on a beta blocker, not a beta blocker. Really, there was no reduction in portal pressure. When you looked, however, at those who were compensated, who had very high HVPG greater than 16, you can see that a post hoc analysis did reveal that there was some benefit using amikacin, but really no dose dependency, and the reason for this differential response in HVPG is really not clear. So we've talked about inhibiting the injury, the inflammation in NASH, and looking at whether or not there is fibrosis or cirrhosis regression. But just wanted to mention a study where if you stop the injury, right? So we're curing hepatitis C, patients have cirrhosis. One, their HCC risk may remain, but also many of them don't then resorb. So getting back to, is all cirrhosis reversible, and whether or not, depending on where you are in the trajectory, it may be too little too late. But also, can we facilitate, can we promote or help regression when we have eliminated that injury? And so HSP47 is a molecular chaperone that binds triple helical procollagen in the endoplasmic reticulum and prevents inappropriate collagen unfolding and aggregation. This BMS drug is a retinoid conjugated lipid nanoparticle that has siRNA targeted to the HSP47. So it's going to go to your hepatic stellate cells, and it disrupts collagen formation and promotes hepatocyte apoptosis. Again, kind of that regression. The goal was to take F3, F4 patients and then randomize them to placebo or 45, 90 milligrams every week IV infusion, another liver biopsy at week 12, and then a follow-up period. With this study, however, what was interesting is that the local pathologist, right, for screening, you're just going with the local pathologist read. And so patients were eligible if their pathology report from their local pathologist called them F3. Well, when the central pathologist looked at these, 52% of those with F3 were actually F1, F2. So they were really much, much less fibrosis than expected. Nevertheless, a 17% in the 45 milligram and 20% in the 90 milligram had a greater than 1 stage improvement in fibrosis, and 5 patients in the 90 milligram had a greater than 2 stage improvement. And so obviously, since this is targeting kind of active collagen formation, it may be more potent as a therapy or a combination with other therapies where there's active fibrogenesis. And this is being studied for NASH right now. But I think facilitating regression once we're squelching that upstream injury is another area where, particularly for cirrhosis, we need to develop and think about therapies. So getting back to cirrhosis not being a single stage, I hope I've made the point that cirrhosis is reversible, but it depends on where along this trajectory you are. And that could be very patient dependent. It's going to vary patient to patient, and there won't be any kind of clear cut, okay, now you're irreversible, and you know that for sure. So let's talk a little bit about how liver biopsy is problematic. I think we all know about sampling error, but this is the best slide, I think, that just kind of makes the point. If you were to look at this clearly, we're looking at this full kind of screenshot. The patient has nodules, they have cirrhosis, but if you were to measure the collagen content and your liver biopsy needle was going through that trajectory, you would think they have 65% collagen. However, if you just went slightly lower, you would see that they have only 15% collagen. So certainly we understand sampling error. But we have to also think about fibrosis more quantitatively and not just categorizing F1, F2, F3, F4. How much collagen is there? And with AI technologies and machine learning, can we be more reproducible than we are currently seeing with pathology assessments? So liver collagen bundle accumulates and is not linear across fibrosis stages. And in fact, dramatically, you can see the slope increasing once you hit F2, and then certainly from F3 to F4. But even within these stages, there is a tremendous amount of variability in collagen content. So even though, yes, you're F4, but one individual could have 30% more collagen content than the other F4, two very different patients, and therefore their reversibility is going to be very different. So there's a number of techniques that are out there now that are being used to be more quantitative. This is histoindex. I'm using the slide with their permission. But see, now you start to think about, okay, what's the thickness of that bundle? What is the septal width? What is the cellularity? Because we know that it is the cells that are going to make those matrix metalloproteinases to degrade the scar. If there's no cells there, it's going to be very hard to infiltrate. And this approach has been validated to assess fibrosis changes after Hep B therapy and is currently being evaluated in NASH, and they're part of a number of clinical trials, as you all may know. But the idea is we need to be more quantitative when we want to talk about fibrosis regression. This is Fibronest. As another example, making the point of the fine collagen fibrils, this kind of feathery stuff that's going to be really easy to degrade versus that locked in fibrosis. So these are just examples, but I think to make the point that not all cirrhosis is created equal. So what have we learned from anti-fibrotic trials to date? Treatment of cirrhosis, one, obviously will require long intervals. If it takes many, many years to get there, we can't expect reversal in 6 months. And will require better stratification. It will be reversible in some, depending on the time they've spent in that cirrhotic phase. The point of no return will vary from patient to patient. We need better techniques for assessing the effect, and we need to understand genetic determinants of reversibility. They may be the same as genetic determinants of progression, but that remains to be seen. There may be genetic determinants that really focus more on resolving fibrosis. The high placebo response rates have, been up front and center in all of the clinical trials, and that speaks to the natural history potentially of NASH, the fact that it's a very heterogeneous population, and it's really the post hoc analysis that will help us identify subsets of patients or subphenotypes of NASH or whatever disease that are more likely to respond to a particular drug, because in that patient, that is the main driver of their fibrosis. Sampling variability and inter-observer lack of concordance in the kappa score is clearly an issue on biopsies. And then the non-invasive markers, we're getting better. They just need to continue to be improved. They need to be combined, paired with biopsy for validation. And I think my other theme is everything has to be moving in the same direction. Once there starts to get all this like discordance, then your confidence level in that therapeutic approach goes down. Pro-C3, 3M ratio, ELF certainly now as an FDA approved test has received a lot of positive results in clinical trials suggesting that it can predict the risk of progression. We know MR elastography is excellent, but not always available. CT1 MRI, FibroScan, and I think ultimately, we got to get away from biopsy. We need to seek early biomarkers for response before having negative, phase 2b3 trials. For NASH, a reduction in MRI PDFF of greater than 30% may predict a fibrotic response if your drug, if that is the expected mechanism of action for your drug, right? So if that wasn't the mechanism of action that you think your drug would, then that's obviously not an early biomarker that's going to predict fibrotic response. Collagen content continues to increase rapidly, even in cirrhosis. Morphometry is more sensitive than Ishak or Medivir scores and allows for this continuous scale as opposed to this kind of staging. AI-based techniques to address inter-observer variability of pathologists and combination therapies and cell-specific targeting may be critical. There are a number of anti-fibrotic trials that are ongoing in cirrhotic patients. Intercept, reverse, galectin is ongoing, pegloid FGF21, etc. And so we look forward to continuing to move towards having drugs that can be used as anti-fibrotics. And so with that, I will end and hope we can have a robust discussion.